Hello and welcome, Elsa.
Good evening. Thank you.
Yeah, it's gonna take a little bit for all of the entrants. If you see a window that says recording and asks for an okay, just click it. Um, Elsa, where are you calling in from?
I'm calling from Cape Town, South Africa.
Wonderful. So glad that you're here. We have registered, we have a huge number of people from all over the world. Huge, relatively speaking, but there are 12 people that are participating this at this time, and then there are 16 more participating at the later time. So thank you so much for joining us.
Thank you for having me here.
I'm going to wait a little bit to see where we are with attendees coming in. While we're waiting, Elsa, would you like to tell us a little bit about what your role is in South Africa and what brought you to Marseille, this salon?
Yes, I'm a perinatal psychiatrist working in Cape Town, private practice. I don't know how familiar you are with South African medical system. It's quite different, the state system versus private system. Private system mostly medical insurance driven, whereas the state system, of course, we have great discrepancies in terms of wealth in my country. And so the vast majority of people will go through the state system where they won't need to pay for medical help, but the resources are scarce. So my private practice is solely perinatal psychiatry. And what I didn't realize when I started out was the amount of grief and loss that one see. I thought I was gonna just do, pharmacology in pregnancy and helping women through the pregnancy. And then as soon as the gynecologist realized, oh, there's a psychiatrist for pregnant women, you find that you also get your neonatal losses, your late miscarriages, and other complex losses. So, women with small children and traumatic losses. So that have actually, without me signing up for it, became part of my practice. And so that is what made me interested in this particular discussion.
Great, great. How did you get trained in the area of pregnancy loss, or what?
Yeah,
What
we
was
don't
that
have
like
a
for you?
subspecialty in perinatal psychiatry or loss. So for me, it was a lot of really hands-on clinical training as to people came, and I just had to swim, and well, it was a question of sink or swim. So it was really a lot of practical training. I have a really good circle of psychologists and people that are very skilled in bereavement and grief. And so I spoke a lot to people that had more experience than myself and just read. So I had actually no formal training in terms of bereavement and loss. I guess it just came with the years working in that area. It's not my main focus of practice still. It's, as I said, it just sort of happened because where I was situated.
Right. Are there any specific um, training programs, or are there any specific services that you're aware of that are focused on perinatal loss?
Not much in our country, no, no. So it will be, I think it's very, in some centers, people are very aware of these things, and there's quite a number of skilled healthcare workers that you'll be able to send these mothers and fathers to. But in others, there are really very little help. So it differs a lot in terms of where you're situated in the country, whether these mothers will get any guidance or support or not.
Got it. And are there support services for perinatal mood disorders where it's not necessarily psychiatry or even psychotherapy, but support group oriented?
Yeah,
Or
there are
things like
some, but
that?
again, they are really, it's not a system that is uniformly rolled out throughout the country. It is very much available in some societies and others not. And depending on how close to hospitals you live and how far out rurally you are. So it differs. There are some support systems, but they're not regulated.
Got it. I'm just looking and I see that we have Nia. I'm wondering if you might turn your video on so that you can participate and we can see you and meet you. And also unmute so we'll be able to have you introduce yourself.
Hi, sorry, my camera is giving me issues right now. I think I'm gonna log in and try to sign in with my other Google account, which is linked to my Zoom. It somehow signed me in without logging me into Zoom. So I'm gonna try again,
Okay.
okay?
Okay, great,
All right.
thanks. While we're waiting for her, I'm going to do a introduction when I have a sense that the people that are coming are going to be here. I imagine there's other people with technology challenges. Let me ask, so Elsa, in South Africa, is English the primary language?
I did no. We have 11 official languages. So English is really widely spoken, but our Nguni languages like Xhosa and Zulu speak far more. Although I think Afrikaans and English is probably the languages where you will be able to get most help in terms of medical help, any medical help and psychological help. So most people in South Africa can speak more than one language. Yeah. So, but English probably one of the widest spoken, not necessarily as a first language, but a lot of people can speak English. Probably most people you'll see, not rural, but in the cities or towns will be able to speak English.
And in university and medical school, is that taught in English?
English and Afrikaans, and then we also have Xhosa universities.
Okay.
But mostly, especially once you get to your tertiary education, will be holding mostly English.
Good to know. Well, let me go ahead. Oh, now she's back. Just a minute. Nia's trying, aren't you?
How'd you
There.
guys
Ah,
work?
yay.
Hi, everyone.
Here you are. I'm glad to see you. I think the thing with international and technology. So I'm gonna just have us keep going and I'll have just a minute. I'll have you introduce yourself, Nia. We've met Elsa from South Africa. And Nia, tell me, where are you calling in from?
I am Nia Dond. I am a perinatal and reproductive psychiatrist, and I'm calling in from Chicago, Illinois.
Great. And am I pronouncing your name correctly?
Nia is correct. Yes, thank you.
Okay, good. Thank you. So let's go ahead and I'll introduce our inquiry hosts. So this is the first of a series of salons that spotlight training models globally and training models in perinatal loss and perinatal bereavement. And the first one is Resolve Through Sharing, which is an organization that I trained with in 1989. And we are fortunate to have with us the co-founder, Rana Limbo, who trained me and has been a mentor to me for all these years. And I am on the national faculty of Resolve Through Sharing, which is a contract role. I teach a couple or three times a year for Resolve Through Sharing as an independent contractor. And it's always good to start a series like this from scratch, never done before, with people you know. So they were very gracious to just give it a whirl. The salon is also not a very familiar structure. So the goal in a salon is for us to share where each of us are coming from, what our knowledge base is, and for you to be introduced to Resolve Through Sharing and their approach to perinatal bereavement training. And then for this to be really a think tank, both for them in how they develop and update their evidence-based curriculum, and how we can bridge reach of training. So in this case, Resolve Through Sharing, how we can bridge training models globally so that we're not reinventing the wheel. There may be things that you can adapt just from learning about any of the programs that I'll be spotlighting. And also it's an opportunity for you to ask questions of them about ideas you have about implementation. And our goal is really for everyone to go away with some ideas that are going to percolate in improving what services you are offering. With the idea that we're also going to be the think tank surrounding some of the development areas for our inquiry hosts. So I would like to introduce you to Rana Limbo, who is the Director Emerita of Resolve Through Sharing Bereavement Services in La Crosse, Wisconsin, and Daryl Owens, chaplain and of the Women's Service Line in North Carolina Hospital, who is also on the national faculty for a very long time. And I'm going to turn it over to you, Rana, to give us an introduction to Resolve Through Sharing training approach to perinatal loss and your own background, and then we'll have Daryl also introduce yourself and what drives your investment in Resolve Through Sharing training model, and then we'll open it up for discussion. So over to you, Rana. You're still muted.
That should help. Okay, so it's very nice to be on the call with all of you and to be part of this innovative way of bringing professionals together to discuss this important topic. I am a co-founder of Resolve Through Sharing, and I think back often to 1981 when the first training was held. It was a local training at that time at the institution where I worked. And it was taught primarily by bereaved parents and two nurse practitioners who worked with high-risk families during a pregnancy. And of course, in a high-risk population, there's a lot of loss. And both of them felt that we needed to do more as an organization and as bedside care providers to bring support and help with healing. So that's kind of what framed that first course. And at the time, Sarah Wheeler and I were doing various talks at national organizations. And we happened to be at an organization called AWAN in Washington, D.C., and there was tremendous interest in what we were talking about, which was perinatal loss. And we learned at that point that this is something that people really are asking for and want. So when we came back to our hospital, they said, in order to do something like this, we need to have a team approach. We need it to be interdisciplinary, and we need it to be based on theory and practice. So that's really the model that has sustained us for all of these years. And I'm very happy that that was the case, because there were, at the time that we started, a few parent support groups. So that was a model that people were used to, but the training of professionals who work as care providers was something new. And we tried to get at what was needed, include that in the training, and that's still what we do. So that's probably enough about the history and the reason that I'm on this call today. I retired in 2018, but I still do quite a bit of volunteer work for Resolve Through Sharing. And I've done research. I'm a PhD prepared nurse, and I've been a researcher, speaker, writer, and been involved in professional organizations that have bereavement as their core mission. So thanks, Deb.
Thank you. I have questions in my head, but which I'll come back to. But Daryl, we'd love to hear from you.
Yes, good afternoon, or morning or evening, wherever it is for you, Elsa. I was thinking in terms of Naya, you're an hour behind us. So I'm here at the University of North Carolina in Chapel Hill at our medical center. And I was actually, like Deb, trained by Rana back in about 2001 is when I was trained. I've been on the faculty since 2004, and Rana trained me for the faculty as well. My connection with this is that I've enjoyed the training, and I still enjoy being a part of it because of the interdisciplinary approach. I've loved also being a part of this program because, first of all, like Deb said, Rana has been a mentor in writing and publishing and just being. And I've enjoyed bringing a minority perspective as far as a male, a bereaved dad, and also a person of color, and the spiritual aspect as well. Of course, that is going to be seen differently in different parts of this country, and I'm sure outside of this country. But bringing in the different perspectives, because actually when I started, I didn't even connect with a bereaved, my wife and I had a much earlier loss when I was going through training here at the hospital as a chaplain. So it's been really, really delightful to be a part of this group that's looking at it through different lenses, and it enabling me to teach our OB residents and faculty and things like that. And I love being here in my particular hospital because, as I've heard Elsa and Naya, you speaking about your professional identifications, my hospital is one of the few in the country here to have an inpatient perinatal psychiatric unit. And I get to serve that unit as well, and do twice a week, do a spirituality group with those patients as well. So it's been great to see it from different perspectives and to be able to offer whatever I can to this wonderful program that trained me. So that's my role.
Great. And Naya, tell us some more about where you are and what your role is. I mean, what setting and where and what your role is.
Sure. So I am an outpatient psychiatrist. I was working with a group practice in Chicago, Illinois. I'm actually right in between starting my own practice in January. And I'll be serving mostly women and parents, people who have gone through challenges with preconception, like premenstrual disorders, pregnancy loss, infertility, and then perimenopause, kind of all around spectrum of like reproductive psychiatry. Um, I have not worked inpatient in years. So that's something that is not like my biggest strong point. But I do have a personal touch and connection with perinatal loss. I am someone who's experienced it myself. That's not like what led me to being a psychiatrist in this field, but it did draw me back to do a second fellowship in reproductive psychiatry at Northwestern University under Dr. Crystal Clark and Dr. Kathy Wisner, who are experts in the field. Really grateful to have learned from them and work with them. And so, having gone through perinatal loss and it was like a mid-second trimester loss that was pretty bad, and then like years of infertility, it really drew me back into the field. And so I offer a lot of that like personal perspective empathy, I think, to the patients I work with. Not all of them know that's something that I've experienced, but I do think that it impacts my ability to connect with those patients.
Yeah, yeah. I too was a trained psychologist and then had personal experience of a full-term stillbirth, which moved me into, that was in the 80s, and there was very little training of the professionals that I dealt with. Although my personal patient experience was excellent, I looked around and thought, why is it as a psychologist that no one ever talked about this, and there was no understanding of how that shaped one and what kind of interventions would be helpful. So I started just doing training locally and then found Resolve Through Sharing, and got further training and got more involved. And I think that in my experience, I think you would echo that, Rana and Daryl, that a lot of the professionals that we encounter have been were already professionally trained and may have moved more into this area or expanded on their expertise out of personal experience and noting the lack of resources. So just an impassioned kind of investment. Well, it's helpful to know we are all in different places. Four of us, four of us in the United States, Elsa in South Africa. So as we're thinking here about training models, Elsa, you mentioned that there really weren't any that you were aware of. And Naya, what has your awareness been of access to training that you as a professional have participated in or are aware of in your community or out? Did you know of Resolve Through Sharing, Naya, before this?
No, I didn't. I was like, I have another tab open where I'm like reading about it. The training, I haven't done specific training in perinatal loss. I've done what comes with like the fellowship training, which was expansive in its own way, but missing parts in other ways. Then I did a lot of like trauma therapies, which overlap, and we did focus on perinatal loss, part of that narrative exposure therapy, as well as written exposure therapy for the perinatal period. But I'm still looking up more about the Resolve Through Sharing, the website and everything.
And Resolve Through Sharing also partners with an international perinatal bereavement conference that Rana and I and Daryl have been involved with for a very long time, that is specifically focused on interdisciplinary providers in perinatal care that are going to be working with perinatal loss. And that next conference is in 2026. I'm not sure if it's only going to be only in person. We've adapted through the pandemic. But it's called Pregnancy Loss and Infant Death Alliance, PLIDA.org. I can put that in the chat when I'm not talking next. But those are really the two key in-depth, deep dive training resources in the United States for professionals. So the focus is on professional education and support around the work that they do with perinatal loss families, and looking at the interdisciplinary approach. So what questions, Rana and Daryl, what questions do you have of our Marce participants that would help you as you continue to evolve with RTS?
Well, for me, that word evolve is where what I was kind of hitting on, because I was thinking as I was speaking about being a founder and a co-founder, and then the changes that have occurred in 40 plus years, and how evolution is inevitable if one is evidence-based and practice-based. And I'm wondering from the three of you, Deb and Naya and Elsa, what have you seen in your own work that is evolutionary, where you've added things to your practice or you've learned new things that you've been able to apply? I'm really interested in knowing about that.
Rana, can I maybe make a comment before we get to your question? I was just thinking now when you know, each of you shared your losses, that I think one of the challenges for me with perinatal loss is exactly listening to how different it is for people and how different in the different trimester losses and the way the losses happens, and that the therapy, the path is not always applicable or the same to everyone. And I find it difficult to think how to create groups or support groups, particularly for women in that time, because it's so very different. It's so different. First trimester loss versus a stillbirth, versus a woman who had twins and lost one in the NICU.
Yes.
So I was wondering if you could comment on that, because I remember we were talking a while back, me and one of the psychologists, and thinking we really need a support group, but where do you fit these women? Specifically, I think the late second trimester women, because for them, it's a life, it's a child, it's something that's real, versus, but one need to be so careful to add them to groups where there are parents that lost older children, because you can get these comments of, you know, it wasn't a child with so many memories, or, you know, things like that. So I was wondering in your practices as well, if you find that the loss is very different in terms of where women present to you, and also to the partners. I think it's very different for the partner. If we look at the reactions of, again, I'm going to go back to, you know, your first trimester, because we see so much of that, but versus stillbirth.
I'll just try to quickly do this because Daryl and Deb, you may have some ideas about this too. I think when you asked that question, I thought right away of parent support group, because when Resolve Through Sharing began in the fall of 1981, the support group began in October of that year. And I happened to be the professional facilitator for that group. And what you're saying, I mean, it was so evident going around the room how these experiences we may we may put them in the same category of perinatal loss, but each person who told their story had a very different story. One of the women who'd had an early miscarriage was still struggling with the fact that in early pregnancy, she fell out of a canoe and she was still wondering, did that cause it? And so others didn't talk about guilt or what caused things, but they might have talked about the true trauma of what they experienced. So the group did not include parents of older children. We did include perinatal, and that meant miscarriage, ectopic pregnancy, stillbirth, newborn death. And I think that even that first time we had people that had had all of those experiences. And so I would say that the narrative is so, I think you mentioned that before, someone did, about the narrative and how important that narrative is, because I think we're going to see themes that cut across everyone's experience. And at the same time, we're going to notice some profound differences in how the impact that this had, how they approach, for example, a next pregnancy can be very different. What they choose to do in a memorializing way can be very different.
I think you're probably going to see that in a homogeneous group as well, because each one's experience is so unique and so different.
One of the ground rules for the parent support group was something like, each of your experiences is unique and valid. I think those were the words. And that always stood out for me because I thought it was so important to say that. And I was a little concerned that because of all the different experiences, that there wouldn't be a bond that formed, that there would be separateness rather than connecting and joining. And I just didn't need to worry. After that first meeting, I realized that that was an unnecessary concern.
I think from an evolutionary perspective, that as this life experience has been discussed more in the public view and preparation, and services have expanded, that we've been able in some countries to offer gestational age specific support groups, and even more specific than that. But early in the process, we realize we have to be realistic about who there is to run these, and how how spread thin we can be, and will there even be a critical mass of people. That's one thing. And another thing currently is, since the pandemic, has been the move to virtual groups.
Yes.
So the trade-off has been, you're not in the same room, but the advantage is you get a much broader reach of people, no matter where they live, to be able to join support groups of a wide range of topics. And so you might think about where it's possible timing wise to coordinate with support groups that might be in the US or in Europe in English. And then so that's also going to be, as we get broader exposure and a spotlight on the need of perinatal loss, then there's more referrals into those services. That has to kind of go hand in hand with the professional training, I think, which is so important about Resolve Through Sharing, doing interdisciplinary care, because the pregnancy loss patients have intersected with the system. From the point of diagnosis of pregnancy, there have been multiple opportunities and multiple disciplines that they intersect with. So I think that's an important aspect of what RTS does as training, is their approach is multidisciplinary, and their approach is starting with what happens at the point of diagnosis of loss, and then with a kind of a planned handoff to the other professionals that won't be at the bedside. So I wonder if you could say more about that, Daryl, in terms of your experience and in response to Elsa's question. And
Yeah. And one thing that initially came to mind was what the loss symbolized for the parents, the other parent, and the history of grief, the history of loss. I, like Rana, have done several parent groups, and we had them from the earliest of miscarriage ectopic through NICU losses, where the babies had never left the hospital. So all of them had a unique experience where none of the parents had their babies to be at their house, their home. And
Right.
it was really amazing to watch the alliances that build throughout the time that the parents themselves did. I did it along with a social worker. So we were more, we did less talking. We would set up the format, and the parents sort of carried it, so to speak. And it was amazing how they were there for each other, creating space for the importance of the losses, no matter what. Because, like Rana was mentioning, I've seen some with the earliest of losses, and the grief expressions were just as palpable as someone who had had a stillbirth. And because of various reasons. So I think one thing that the parents always connected to is that we all have a story of loss. And again, as we're talking about this, I do want to make sure that we're not just thinking about the birth mom, but the other partner as well.
Carol, how do you recruit these women? Because you know what I see often, and that's made for quite a complex diagnosis and also dealing with, is I often see women come with a second pregnancy where they didn't deal with the previous loss, with the trauma. And then once they're pregnant, instead of, oh, I'm feeling better, all of that trauma experience come with and a lot of anxiety in the subsequent pregnancy. And you know, then you got to work through the loss first, really, to actually get to the pregnancy. And so you have to work with this. It's almost a diabolical situation where on the one hand it's the expectation of new life, but on the other hand, dealing with the loss. So I'm wondering, the women coming to your groups, do they decide themselves they come to you? Where do you recruit them? How soon after the loss of a baby does that happen? Because I think sometimes my problem is I see the clients that didn't deal with it, that just, you know, soldiered on and try and do something else to fix it, and then it didn't work. So it's wonderful, those type of groups. I'm wondering if it's sort of two populations, or you know, where someone is ready to come and talk, or whether because the service are there, they just feel they'll jump in and see where it takes them.
so, you know, I want to put a pause on that question so that we could come back to the focus of training models. And those are really important questions that I have been thinking for a long time about whether Resolve Through Sharing might offer a consultation service. And some of these questions that you're asking here really are in line with, so just kind of to focus back to you, Rana, for Resolve Through Sharing, consideration, and maybe we can even elicit more information from the special interest group that would be useful to Resolve Through Sharing in terms of consultation service about the kind of questions that Elsa's asking about patient care. Oh, I needed to leave to see a patient that came in. So the evolution, I think that you're back to Rana's question about evolution. As a professional, needing the things you're asking for, our professional consultation, and that type of consultation is not covered by this training group, right? But you're raising an important point in terms of training models is what are we thinking, what are we doing about consultation? And so if, I will say in my evolution as a psychologist, there are very small numbers of psychologists and therapists in Resolve Through Sharing who have a similar experience to you. I was the coordinator in a medical system for 13 years. So I was actually at the bedside and training those professionals and seeing the gap between what they did at the bedside and then what you received or what I received as a psychologist, psychiatrist. And in my professional evolution, I've developed a training model that bridges the medical and the psychosocial, which I think is absent from our professions. And it's hard to generate enthusiasm, I think, for the intensive training that RTS does, with the idea that I don't need to know that. I get the patient when they come in. But I think it's really, I think it's essential, which is why I invited RTS. And my evolution has been to notice that people fall off the conveyor belt, that there's this amazing training of the people at the bedside in the clinic, and not that knowledge, even understanding of when you meet the patient at the second pregnancy without really knowing what they could have had, should have had, didn't have, that impacts treatment, that and I see Resolve Through Sharing in your evolution, Rana, of the, I don't have input into the curriculum, that Rana and the key staff have, I think they're up to 13 or 14 editions of evidence-based training so that it's current, and more multidisciplinary people are involved so that we're doing a better job of bridging the patient journey. So I think your questions really are important, Elsa, in pointing out that gap. And one, so I said a whole bunch of things. Rana, maybe you can jump in next as far as what you would like to know for RTS from us and Daryl as well, and your experience of what RTS training has brought to you in bridging those kinds of things. What questions do you have about your ability to bridge from RTS?
One of the things that's been on my mind as you were talking is that we've always believed, and I think that we've spoken about this today, but we've always believed, Elsa, that new things come to light in perinatal bereavement. It's, as you have spoken about, the experiences can be very different. And the more we learn from parents about those experiences, the broader our knowledge base is. And now at this point, I'm writing with a co-author, a guest editorial for a journal on adding traumatic birth, disrespectful care, and maternal death to bereavement. And there was a concept analysis that two authors did in 2013 that didn't include those things. But one of the things they said in their conclusion is, as we move forward, there may be things that come up for us that need to be added. And that's just one example, I think, of where we will find bereavement where we weren't looking for it before. Or we didn't have the knowledge, we perhaps hadn't heard the stories. But now there's also some good literature, some good research on the effects on care providers of traumatic birth. And so you're nodding. And I think that is such an important point, is that we probably were more patient and family focused. I know we were in the beginning. And yet, as we've grown and become more broader in what we're looking at, we know that the care providers are also included in the idea of perinatal loss. And how do we support them? What do we do? What do they need? So,
Because
Deb,
I was wondering,
go ahead.
Thank you, Rana, because I was actually wondering about that, whether in your definition of loss, whether you include, because I do see a lot of women where they are really grieving for not having the birth experience that they would have liked to have, for not being able to take their little one, for that, even if the baby is fine in the end, but that first 3-4 weeks staying in NICU, not having it the way they thought they do, it's really a traumatic loss for them. And I think, unfortunately, in my country, and I think many other developing countries, where the state system are really overloaded in terms of doctor versus patient ratio. I think it's very often that mothers are traumatized at birth and feeling that they don't get the help that they needed at the time where they were very vulnerable. And so I think there's a lot more of that than what we actually know. And so it's very good to hear that you are looking at that as well.
Many years ago, I worked as a bedside care provider in the mother-baby area. So I took care of mothers after they delivered and with their babies. And I don't know why this experience has stuck with me all of these years, but it has. I was working a PM shift, and there was a couple that she was admitted. And so they were both there because she was going to have an unexpected planned cesarean for the next day, but it hadn't been planned for very long. And I remember the profound sense of loss that they were expressing. And I had other patients as well, but this couple kind of took most of my time and energy for that shift. And I was able to do that. We worked on their birth plan, how it had changed, what would be different now, how could we do this in a way that fit with their norms and values. And I've always felt that a couple like they were could have easily been ignored. I mean, not bad care, just not thinking about that could cause a lot of grief, that the unplanned delivery method can be a great sense of loss. And I knew another professional when I was working, who I think still to this day would say that her greatest grief in her life was an unexpected cesarean birth. So what you're bringing up is so important because it means we need to be cognizant of how this is perceived. Really, what matters is, what does this mean to you that this birth is going to be different than you expected? Meaning is tremendously important in this field. And so we can get at what could we do to help you have the kind of meaning you want from this experience. And anyway, that I'm really glad you raised that, because it's been part of the growth and the evolution that I personally have experienced in this field by listening and talking with families.
You know, I think
I
from
could-
my side, where I work from the mother side and seeing before the time happened, I became so much aware of the language we use in how we, you know, in like well-meaning campaigns, but then something like a cesarean section, which can really be life-saving to mom and baby, get sort of, women might feel inferior if they have a birth like that. And I think we as healthcare professionals need to be so careful how we drive these well-meaning campaigns that we have, in not causing harm to moms, because it's very difficult then for them to shift from, I'm now not a good enough mother.
That's right.
Yeah,
And I also think that there's a phrase that's used so often, at least in our country. I'm not sure for you in South Africa, but the term is "at least." And this is other people's desire to make meaning out of this experience, and they, for someone else, which we can never do, but it starts with "at least." At least your baby's healthy. At least you knew about this in advance. At least you're okay. On and on and on. And I think if we could stamp those two words out of our language, we would have done a great service to families, because nearly everyone has heard it. I mean, it's
I
just,
usually warn mothers that they're going to have to decode a lot, because I think people in general we are really inept and bad in sitting with other people's loss, and sometimes that's all we need to do is just sit there. You don't need to, you can't make it better, you can just be there. And so I warn the mums that you're going to have to decode. Remember, they probably mean well, but they will say terrible things that will feel terrible to you. So, and it comes down to the at least, you know, which often, especially in early loss, the mums are really not, you know, not ready to, I don't know whether you're ever ready to hear anything like that, at least.
exactly.
yeah.
Daryl,
Yeah.
you were going to make a comment.
Yeah, I was going to say, it's interesting that you're discussing this, because I sat with a physician who went through the same grief, because she herself was having a C-section, an unexpected one, and the baby's heart tones again. The baby came out okay. She gave this information to other patients, but when it was happening to her, the amount of grief that was pouring out. So I was able to be with her, and with with a nurse recently who, her first child, she was preeclamptic, and they had to do an emergency C-section, and they had to care for mom. So she could not be with the baby initially. You know, they had to make sure that she was medically stable. And she still did not forget that. She recently had that baby survived. She recently had a subsequent healthy birth many years later, and was so into taking care of her grief with this subsequent pregnancy and how she was going to make everything happen. Like, for instance, with the first one, she nor her husband were able to be the first ones to hold the baby, because they were, you know, making sure she wasn't coding and things like that. She arranged that this time, this is how it's going to go, bar any medical emergencies. And thank goodness it came out the way she wanted. And she was able to address her grief from her first delivery so many years later in a very different way. So I like the fact that you're both bringing up things about not just the birth experience, but also providers who are experiencing it themselves, whether it's directly or if they're the ones who are caring for like a maternal loss or unexpected, newborn death or whatever. There's grief all around that has to be honored and looked at.
So true.
Daryl, I wonder if you could reflect on the evolution of paying attention to partners and fathers, and how I'm thinking useful for Elsa, who's probably oftentimes not seeing the other family members or partners, but what your evolution has been in recognizing that importance and how to deal with that.
Well, we have a chaplaincy training program here at our hospital. I'll give you this little segment. We have and he gives me permission to use this story. We have a student now who came to our program because some years ago, he and his wife experienced a stillbirth, unexpected. And he said, this is not tooting Daryl's horn. It was just because of the wonderful training and mentoring I've gotten here. I asked him how he was doing when I came into the room. He said, nobody had asked me that. And it took him aback. And as a result, he wanted to give back to others. So he wanted to come to our training program to be able to do that for other fathers and other parents as well. So that's an evolution that I see. Does that answer your question, Deb?
Yeah, thank you.
Yeah.
Yeah.
So it's very important that we remember that other parent because they're experiencing things as well, especially the helplessness of not being able to save the day for either their baby nor their partner.
Daryl, do you
We just
see?
have a few minutes left, and I'm wondering what questions Rana, as in your RTS role, what questions you might have about how RTS might be a useful resource to Elsa and to the development of programming and training in the wide range of South Africa, but just to get maybe some pointers about, and vice versa, about pointers about how a bridge might begin to be built.
Well, one thing that has been on my mind, and Elsa, I'm going to write to you about this and let you know the details. I was part of a grant. Two of us participated in a workshop that's done every year. And I don't remember now exactly where. It was north of Johannesburg because we flew into Johannesburg. And I thought I would maybe give you information on this. I don't know if you already know about it or not, but it was a perinatal workshop. So grief was part of it, but it wasn't the sole topic. And we did a ritual at the end. It's with dissolving paper. So they put their paper in water and it dissolved. The story is that this was extremely powerful. And I want you to know about this workshop just in case it's something, in terms of training that you and others may want to attend or perhaps speak at. I could see you really having a lot to offer to this group. So I'll do that.
I'm having an idea as I'm sitting here, because we're having next week is our biological congress, the South African Society of Psychiatry, and I'm conducting a women's mental health group there, and the executive committee, of which I'm part of, that is part of sort of a subgroup of the Psychiatric Association. We are thinking a lot about teaching and next year, and sort of developing women's health. And I'm already thinking we should talk about perinatal loss and how we can incorporate that. So thank you so much. It's so helpful to hear what you are doing, and to take some of those parts and make it applicable here.
It's been wonderful talking with you.
Yes,
Yeah,
definitely.
thank you so much, Elsa, for participating so actively and deeply. And this was going to be a surprise about how it would unfold. It's definitely been rich and fruitful for all involved. So thank you so much. And then Rana, you'll be connecting with her offline so
I
that
will.
you're able to have this fabulous resource now
Thank you very much.
moving forward.
Yes.
Yeah.
And Deb, do you already have her email?
I can get it for you, yes.
Okay. Okay. So Elsa, I'll be in touch by email.
Perfect. Thank you very much. Thank you, Rana.
Sure.
Thank you. So we're going to say goodbye to you, Elsa, and Rana and Daryl. The room will be open a little bit for us to put our heads together
Thank you
afterwards.
very much. All have a good evening.
And Elsa, are you a Marce member?
Yes, I am.
Yeah.
Yeah.
Good. Okay. Well, I hope that I will see you more within the special interest group and also within Marseille. It's delightful to meet you. Thank you.
Likewise. Likewise.